Coming to the oncological benefit between the bursectomy and no bursectomy, we have mixed results in this. There are a few studies which have suggested there is no advantage of doing a bursectomy or no improved survival rates. There is a meta-analysis which suggests there might be some improved overall survival rate. This has been published in 2017, and there was a well-conducted randomized control study which has been done in 2018, which had no benefit of doing a bursectomy, and a D2 resection with with the omentectomy is considered as a standard of care. So what we follow is tumors which are penetrating the serosa of the posterior gastric wall. With the aim of removing the microscopic tumor deposits, we can consider doing bursectomy. And the next controversial thing is splenectomy versus no splenectomy. So splenectomy increases the operative morbidity without much improvement in the overall survival when compared to the spleen preserving procedures. So routine splenectomy is not suggested unless there is direct infiltration or there is significant hilar lymphadenopathy. And coming to the omentectomy and no omentectomy, as a part of radical D2 gastrectomy, we always considered omentectomy. And Japanese guidelines in 2021, they suggest T3 or deeper lesions, we consider removal of complete omentectomy, and superficial T1 and T2 tumors, omentum more than 3 centimeters away from the right gastroepiploic artery can be preserved. So there is one randomized control trial which is ongoing now to find out non-inferiority of the omentum preserving gastrectomy over the omentectomy.
Coming to the other discussion of lab versus open versus robotic gastrectomy, the world has seen a changeover over 2 decades, and there has been evolution from open to lab to robotic now. And now there are enough evidence showing that in early gastric cancers, laparoscopic gastrectomies are equivalent for both distal and total gastrectomy. For a locally advanced distal gastric cancer, the laparoscopic radical distal gastrectomy has been shown safe and effective. Whereas in cases of total gastrectomy, the class 6 trial results are awaited. The trial is presently under recruiting process. Coming to the robotic gastrectomy, it offers lower morbidity rate, faster recovery, and milder inflammatory response, and also an improved lymphadenectomy when compared to laparoscopic gastrectomy. Now we have good number of RCTs and meta-analysis to prove this.
Coming to the surgery for oligometastasis, we have a retrospective study from the CE data which have studied the surgery for the metastasis and the primary, and operating only for the primary in case when there are metastasis, and no surgery group. They found that operation for the primary in a metastasis and leaving the metastasis alone has mildly increased the overall survival rate. And when they have addressed the metastasectomy, when they included the metastasectomy along with the primary surgery, they found that there are increased morbidity and there is no increased survival rate. And coming to the oligometastasis of liver metastasis, less than 3 metastasis of size less than 5 centimeters, and only in the one lobe of liver, there is an improved survival rate in case of liver metastasis.
So to conclude, there have been shift from aggressive resections to function preserving surgeries thanks to the wonderful chemotherapeutic drugs which have evolved, and we have started knowing about the biology of every tumor in a patient specific manner. However, the oncological outcomes have always to be balanced with the quality of life, and we still await certain key RCT results. Robotic gastrectomy may become a new norm, and there is always selective use of procedures like a total omentectomy, bursectomy, multivisceral resections, and surgeries for oligometastasis. However, one should remember that the quality of life depends upon the type of reconstruction. With that, we hand over to our colleagues who will present on reconstruction techniques. Thank you.
Thank you.